And I'm going to go ahead and start.
All right. So welcome everyone to the mental health and wellness subcommittee meeting. I'd like to thank everybody for joining with your time this today. I'm gonna really briefly review the agenda. Um, Today we're going to have Chief Skinner talk a little bit about the COPS Wellness Grant, um, and what the next steps going forward will look like and the results actually of that grant. Um, and then we'll have an update about peer support and resiliency from the PSR team with Emily McCauley, and they're going to review literature and resource lists for officers, and describe the process for creating and maintaining a resource list. What does success look like from the Law Enforcement and Mental Health Wellness Subcommittee? And we'll be closing out with a brief committee discussion about next steps for the committee. This is going to be a shorter meeting today, so yeah. So first, we would need to approve the meeting minutes from September 5th, last week.
Chair, I have a correction on the meeting minutes.
Sure.
On page 4, under where it says Commissioner Booker asked if they were aware of an incident. I didn't say an incident, I said murder. Murder of Sonya Massey, and her name is spelled wrong. It's Sonyamassey. And they're supposed to be aware of the murder of Sonya Massey.
I'm seeing that right now. Yeah, I do remember you saying, clearly referring to it as a murder. So can I second that correction?
As I understand it, we have a couple of options. We can, the way that Vice Chair Shivers explained it to me at our last POCO meeting, we have some room for scrivener's error. I would say, though, that given the impact of the statement made, I think we should make a motion to approve the minutes with the recommended edit from Dr. Booker.
Okay.
Because I think that's an impactful change.
Can I second that motion that you just made?
Absolutely.
I'd like to second that motion.
Okay. Were there any other recommended requested edits to the minutes?
That was all.
Okay. All right, then Chair Parham, you would put that to a vote for all of the committee members.
Okay, so can we bring this to a vote, please? All in favor?
Aye.
Aye. All opposed? All in favor has it. So the minutes will be approved with the recommendation that the wording be changed from incident to murder, and Sonya Massey's name be spelled correctly. All right, now it's time to get into the meat and the potatoes. We are so graciously being joined today by Chief Skinner, who is, I guess, going to give us a little update about the results of the COPS grant.
Yeah, good afternoon, everybody. My camera is off because I'm actually driving, trying to fit this meeting in between a meeting that went all the way to noon and then trying to get to another location for a meeting that starts at 12:45. So I apologize for that. There's not going to be much of an update. One of the things over the course of my career, I've been involved with a lot of grant applications, specifically with the COPS office out of Washington, D.C., which is a subsidiary of the Department of Justice. And one of the things that's often frustrating about the COPS office is that you'll apply for grants, and when unsuccessful with those grants is that you don't get feedback as to why your grant was unsuccessful or how it didn't measure up. These grants are largely competitive grants with other agencies. And one of the gaps is the fact that you just never really know kind of where either you fell short, or in fact you had a really good grant application with a really worthwhile initiative, but it just didn't rank high enough on the list compared to the rest of the people in the country that are applying for these grants. So we're not going to have any sense as to why we were not accepted. One thing I will say is based on the award recipients is you can make some inferences around the award recipients. When we looked at the awards list of the people that were granted the mental health and wellness grants, you had a series of really small agencies. Those are generally agencies that don't have financial means that the COPS office wants to support with their financial resources so that they can do something because they're oftentimes not doing anything because they're financially constrained. And conversely, the other ones you see on this particular list are very large agencies, and the very large agencies have a tendency to do things that are overwhelmingly robustful. And one of the things that happens with COPS office is they like to award grant money to agencies that they're able to study and get kind of a lessons learned or industry standard practices out of, because then they turn around and have you report out on that, and then the COPS office will publish findings as a result of some of the bigger agencies doing, having these massive projects that they're able to take on. The Eugene Police Department sits kind of right square in the middle of those two categories. Again, this is just me speculating why we may not have been successful. This grant is an opportunity that happens every year. And so moving forward, our commitment is to constantly be tweaking what we feel like is going to hit the sweet spot with the COPS office, and we'll continue to keep applying for these grants. But as of right now, we have been notified, obviously, that we were not successful in that grant. We'll have to wait for the next grant cycle, which will be probably they award grants in September. We get these things usually in by I believe June-ish timeframe, and they only open them up weeks in advance, so you don't have a lot of lead time. So late next spring, we'll be looking at another round of trying to apply for a mental health and wellness grant. That's about the update I have on that.
Outside of the two factors that you kind of just listed about size, about like the large scope and the small scope, are there any consistencies that you're seeing between the agencies that were awarded?
Not consistencies in the sense that, and what's hard about that is it's hard to really know the details of those particular grant awardees. What we could do, and we have not done, but what we could do is dig into the grant awardees. You dig into exactly the programs that they were trying to fund through the COPS office and see if there's any commonality amongst those. Now, the hard part about that is that might have been the theme or something that was really important this year, and it may completely change next year. So you got to be a little bit nimble on what you're doing. You don't want to use last year's ideas for next year's grant. But one thing that will happen, one contingency that will happen is Dr. Clary Boos will be attending the International Association of Chiefs of Police Conference in Boston this month. And one of her, knowing her and how competitive she is going to schedule some time with the COPS office, who are always on site, and see if she can dig into some details to better understand. So it'll be good to hear from Clary when she gets back from Boston towards the end of the month.
Dr. Booker?
Oh, yes. Do you know the small agency, maybe not all of them, but the small agency and large agency that actually got the grant, just like the name or location or city?
I don't have that list in front of me, but we do have that, and we can provide that. All those are grant awardees are listed on the COPS office publication, and so you can kind of get a sense of you'll have agency name and state. Any other details around that, we would have to do a little bit of research on kind of where they are in the state and those types of things. Some of the larger agencies are on there are obvious because they're well-known brands. Some of the smaller agencies would take a little bit of work.
Okay, if you can just email us, if would you have time, please, just so we can get a kind of
Yeah.
an idea of the places that were approved.
Yeah. I'll have Clary pull that off the website, and we can send that out.
Thank you, Chief.
Yeah, you bet.
All right. Yeah, I think I had seen Jitson, you had sent me something with like the preliminary, I think like a couple of the organizations that had got awarded.
Yeah, it's public record on the website.
Yeah. So do we have any more questions for Chief Skinner?
I may have tuned out, Chair Parham. Did we have Chief Skinner covered a question about what does success look like from the subcommittee? And Chief, I know we've already asked you this. This is an opportunity for our new subcommittee chair to be able to make plans moving forward.
We have not actually. Thank you for redirecting that.
Yeah, I'm happy to just offer a couple of things. You know, as a subcommittee of police commission, which is tasked with doing good police policy work or making at least recommendations and advising around good police policy work. The subcommittee, it feels like the natural progression for the subcommittee would be around how we identify the things that are already within our policy structure that speak to officer health and wellness, and making sure that policy is good, contemporary, industry standard, and specific policy, and getting those recommendations from you guys where we can do that. In addition to that, I think the subcommittee, along with, in partnership with the police department, and specifically the strategic initiatives manager, this is her job, is to look at, you know, what are we seeing from a industry standard or industry practice, you know, nationwide, on the types of health and wellness, either initiatives, benefits, policies that would make a lot of sense to think about adopting here at the Eugene Police Department. Now, having said that, one of the things that's going to be a challenge that I would just make sure that the subcommittee is aware of is that many of the things that we're talking around health and wellness within police departments also have some level of financial obligation. And right now, financially, we are really, really struggling as a city as we think about trying to close another $10 million general fund gap. And your police department is a general fund department. It's the largest general fund department. That as we think about making suggestions or making improvements, that if it comes with a financial burden, that we'll have to be mindful of that and know that may be one of those things, one of those challenges that we have on getting to yes on some things. So not only good police policy, but also being mindful that what we are suggesting may come at a cost or a price, and being kind of eyes wide open on those things that are happening. We've got, you know, there's innovation happening all over this country around health and wellness of our public safety professionals. We feel good about where we're at, knowing that we always want to be better and we always want to improve. So I would just say success for this group would be, you know, at the end of the year or at the end of whatever period of time, whether it's a 2-year quasi work plan or a year, is being able to look back and ask the question, you know, are our officers safer and healthier today than when we started? And if the answer to that is yes, then what did we as a subcommittee do to contribute to that? And really be able to answer the kind of the how, the what, and the why of this subcommittee will be really important. We'll want to point back. I would think success would mean being able to point back to some tangible things that are showing up in the police department that make us a better and healthier department today than they were when we started.
Thank you, Chief Skinner. So just to reiterate, I think the biggest thing that you're saying is that success would look like us being able to really drill down on existing policy, um, to make sure that that policy would allow for officers to be the safest and best that they can be, at the end of the day.
I would agree, and I don't want to lose sight of maybe some level of innovation that might come out of this subcommittee as well. You know, we don't want to do this in a vacuum, like somehow we're the only ones that know what we need to be healthy. You know, I'm open to entertaining all sorts of creative ways and ideas of how we can be healthier and safer. My only caveat to that, as I stated earlier, is that sometimes those things that we'd love to do for all of our officers cost money, and I have to be a little bit careful about how I allocate funds. I'm losing FTE, have lost FTE, full-time employees, albeit they were vacant positions, but the last several years, every year I've been asked to cut FTE. And so it's hard to think about cutting FTE and cutting functions in the police department, but yet adding other things. That's a delicate balance for me as a leader that I always have to take into consideration.
Thank you. All right. We have Commissioner Rady. Please go ahead.
Yeah, several things directly out of what the chief just said, which is to identify areas of policy where we can make some useful contribution. And having a useful contribution to make based on information about both what is being done, what are best practices, which all of us commissioners do not automatically come equipped with. What resources are available to help us give better informed input? Whoop, what happened to my camera? Better informed input into this committee. Let me fiddle with my camera.
One of the things is that's out there, and we talked about it a little earlier, is the COPS office does a pretty good job of providing publications that help kind of create a baseline of what's happening in the industry around a variety of different issues, up to and including things like officer health and wellness. And so that's a really good, COPS office is a really good resource for that. And I wouldn't expect committee members to be, you know, completely immersed in everything that's going on in the industry nationwide. But that's a good place to start, to think about, okay, even if it went back to looking at the last couple of years of types of innovation and grants that they funded and the outcomes of those grants within other departments, I think the picture will become fairly clear on what are some things that we're doing what are the things that we're already doing that others are just playing catch up on. And then in other cases, you know, what are some of the innovative things that other agencies are doing that have really moved the needle for their staff that we would think about wanting to do.
That's what I'm interested in. How do we access it?
It's a public document, so COPS office is all public record. All of those things are there.
Okay.
Dr. Clary Boos and my strategic initiatives manager, this is something she can likely help with because she loves doing that research and being able to do those things. So between those two resources, I think we get you moving in the right direction.
Okay.
I'm gonna drop the or Jensenia, would you be able to drop the website that
so we don't have a chat in the Zoom because we're on public record.
Okay.
So I said it to Holly.
Yeah, I'll email it to you guys as soon as we're done with our meeting.
Oh, perfect. Okay, that makes sense. And then Commissioner Booker?
Yes. One thing I like to point out that was pointed out in our last meeting that would be good for just and I don't know if you got to see the last meeting or not, Chief, but one of the solutions for policy recommendations, and I think this is helpful for, as you said, being industry standard and studying lessons that can be learned that these grants will look at and seeing that we're being innovative and forward thinking. And one of that is ensuring availability of mental health professionals well versed in law enforcement, culture, and stress, and making those mental health professionals available to officers, and then that person could suggest and give those officers choices. And that was a recommendation directly from your PSRT supervisor, Miss Emily, and that was a great recommendation, because from what we discussed and learned is that keeping everything internal without a mental health professional, and that's just doing a peer-to-peer, is there's nobody professionally assessing these officers, and that's a problem and a danger not only to the officers themselves but to the public. And that's a major problem in terms of outside approval, needing outside approval. I feel like they would need outside approval for return to duty would be an innovative policy, in seeing how we are protecting officers. And a main concern with that was the jeopardizing of an officer's employment and family. And I feel like that's where we can be innovative. The innovation can come from that, protecting and not jeopardizing the officer's employment and family, but also leading the way and being I guess a innovator in terms of making sure that the officers have outside professional mental health professionals that are assessing these officers. I think the peer-to-peer is good for immediate action or immediate solutions. Somebody, going through a suicidal incident, but starting out, but for short and long-term counseling and mental health professionals should be accessible to these officers. And keeping everything in-house is dangerous. There's a lot of data not being made available to us to make reasonable and innovative policy recommendations based off of that, because a lot of that peer-to-peer information is private. But I feel like this is danger to could be dangerous to the officers themselves and to the public if we don't have a professional law enforcement health professional that could be made available to officers, and that person be responsible for assessing the officers and seeing that they are fit for duty and return to duty rather than keeping it internal. And what else? And I think that was it in my point. I just wanted to make sure that I stated that for the record and understanding how to be innovative going forward.
Yeah, no, I appreciate that, and we were really hoping to solve that problem with this successful awarding of this grant, which would break open those funds to be able to get that outside professional that's available to us. So we'll continue to endeavor to do that and to find the finances to do that. One of the challenges that we'll always have is there's just a lack of those competent, lived experience professionals that understand the nuance of law enforcement. And so access is always going to be an issue. We could have all the money in the world and we could have people that want to access resources, and there'll always be a challenge in accessing the right resources for that stuff. So some of this is a bit of a supply and demand. We got plenty of demand, I would think, from our officers to access services, and not a ton of supply in our community to get them there as quickly as we would want to. So we can work on the stuff that we can control, and then hopefully the mental health world will continue to build their competency to be able to meet our needs.
That was a really good political answer.
All right. So in the sake of time, go ahead.
I think Miss Emily has her hand up.
Oh, good catch, Dr. Booker. Emily, please.
I just quickly wanted to piggyback on what the chief said. I agree that there's definitely a supply and demand issue with the culturally competent mental health professionals. Just to clarify what I had talked about last meeting as far as mandating psych reviews or mental health professional sessions for officers was particularly around the legal statute about officer-involved shootings and just being consistent with how we do that. So creating a policy that is consistent. So whatever we choose to do, because there's some latitude in there and the time frame and how you can do that, that we're doing it every time that we have that level of use of force. Just because whenever you do something consistently, then the officer can predict that that's going to happen, and it's easier to administer. But as far as mandating it across the board for officers all of the time, that's a piece that generally is not going to, in my opinion, be successful, just because if someone's not wanting help from a mental health professional, the likelihood of it being a successful review from them is very low. But making it voluntary and making it accessible, finding those culturally competent people and doing that, that's part of what we were trying to accomplish through this grant, like the chief alluded to, and unfortunately we weren't awarded the funds.
And this actually is a amazing transition and segue. Yeah, if you'd like to go ahead and continue and kind of transition into the PSRT portion, that would be amazing.
So I can talk more about our resources if you'd like, but it sounds like according to the agenda, you really wanted me to focus on our literature as far as resources to do with counseling. Is that correct? You're talking about that list of counselors that we currently have, or are you talking about resources in general?
And I think resources mainly focused around counseling, but I think as well, it would be greater resources as well.
Okay. So all of the time we have peer support resources that are available. We do presentations in all of the major groups like Call Taker Academy, Police Recruit Academy, the Citizens Academy, the Sergeant Academy, things like that. So our team and our resources and where they're stored and education around them, we do those consistently. We have both electronic and physical copies of our resources in the department. And so there's an actual physical board that's located just outside of patrol briefing that we've created where people can access their own resources without having to go to a peer support member to get them. And on those boards, we have several things. We have a peer support resource guide that talks about, it has all the personal phone numbers for our peer support people. It has counseling services, helpful websites, different phone apps, calming apps, meditation apps, things like that. It has the crisis lines, the 24-hour crisis lines, and also helpful books. And then we have a critical incident brochure that is really focused towards the significant others, family, loved ones that are supporting officers. But that is something that we generally give to people who are involved in critical incidents. It's also something that the union board has access to. So if they're talking to someone following an officer involved shooting, they can provide that with them. But that also has the contact information for peer support people. But in addition, the really important piece is it has tips on how to care for yourself and others following critical incidents. So it has a piece on how that officer can care for themselves, but it also has an education piece of how their family member who's supporting them through that tough time that may or may not be familiar with law enforcement, how can they support them? And then it has we have an extensive list of counselors that we've vetted through our team, and I'll talk a little bit about how we do that process. And then it has additional resources from our employee assistance program around quality sleep and stressful events. And on that stressful event sheet, which is something that we also review at our critical incident stress debriefs with officers, it talks about what are some of the things that you may experience mentally, physically, emotionally, when you're going through a critical event, and kind of normalizes those things like, hey, if I'm not getting sleep, or if I'm having nightmares, or if I'm having physical reactions, that these are all normal things about stress that, will probably get better with time with no intervention. But if they don't, what are the triggers or those timeframes, and when maybe I need to consider seeing a doctor, seeing a mental health professional or something like that to help with some of those reactions. And getting some outside assistance. So those materials are always available to our people. We use them to educate our employees consistently. If they're involved in a critical incident and our team is made aware of it, we generally reach out to them with a one-on-one contact. That could be in person, it could be over the phone, it could be via text. A lot of that has to do with our access to them, what type of incident it was, and our relationship with them. And if like texting is a normal thing we do with that person, we could maybe do that over text. And so we are just in that time frame checking in on them, seeing what kind of support we can provide to them, seeing if maybe they need time off, if it was a work-related event. And if so, we might utilize our traumatic leave policy. Is everyone familiar with the traumatic leave policy that we have in place?
No, can you email that to us too, please?
Yes, I can. Yeah, I can email that to you. That's part of our post-critical incident policy at EPD. Essentially, it allows any supervisor the ability to grant paid time off to an employee that was involved in a work-related critical incident. And there's 3 ways that can happen. The employee can ask for it, the supervisor can offer it if they see a need, or a peer support member can advocate for an employee to have it. And essentially, it just means that no additional approval up the chain of command is needed. So if you're an AIC acting in capacity sergeant and it's 3 a.m. on a Saturday morning, and someone's involved in a critical incident, let's say a juvenile commits suicide and it's traumatic, they feel like they benefit from going home for the rest of the shift, they can just say, we're going to relieve you from duty, we're going to let you go home, we're going to let you get some sleep, see your family, eat a good meal, do all of those things, and the city is going to pay you for some paid administrative leave rather than you having to burn your own paid time off banks to get that rest. And the whole mindset behind that is generally it takes people up to 72 hours and 2 REM cycles of sleep to process stress. So if they were involved in something, chances are that they're going to need that time off to rest before they can come back to duty. And so that is something that's offered to our people, and it doesn't need approval within that 36-hour window from the event, additional approval.
Now, just real quick, what you saying that, so when you send them home, they're just dealing with this on their own. There's no professional helping them to process it. They're just giving time off to go home and deal with it.
So generally, if they're given time off for traumatic leave, then our team is contacted. So we will then, that's when we're doing those one-on-one contacts and doing those, either contacting them before they go home or right after they've gone home to make sure they don't need additional support. A lot of these events, they don't need a professional clinical intervention. Generally, clinical intervention is 6 weeks or longer after incident. And the reason I say that is because that's generally when something becomes clinical. So in the eyes of like PTSD, depression, anxiety, those things that you may experience from a critical incident, they're not considered clinical until 6 weeks. So up until then, it's considered a normal human reaction. So if you go home after a stressful day at work and you can't sleep for a night or 2, and it takes you a little while to get back on your sleep cycle, that's a normal reaction. If you're 6 months post a critical event and you're still having nightmares and not sleeping from it, we probably need a clinical intervention in the sense that you're not likely to recover from that on your own. So we're still in that time frame of giving them the opportunity to process it on their own. Now, there's lots of considerations, like, does this person live alone? If they do, would it be better for them to be relieved from duty, meaning they're no longer expected to respond for calls for service, but they're maybe at HQ writing reports, talking to other people involved in the incident, talking to a peer support person, things like that, spending their shift doing that before they go home. Or, what does their support system look like? There's lots of factors that we take into account, but a lot of times people are spending that time going home, spending time with their kids, decompressing, exercising, eating healthy, getting more sleep, doing those things we need for them to recuperate to come back to work. And we see that being highly successful. There are cases where they're like, this is significant enough that I do want to contact a counselor, and then we're making those referrals out for them and they're doing that. But generally we see people seeking help from counselors after they can't go through their own process, or they can't use their own resiliency toolbox or peer support or a first line of defense to kind of combat it. And then later they're seeking clinical help for that. So that's kind of what we're kind of the bridge in between their normal coping and a clinical setting. And our team's really good at knowing like, hey, we need to refer this out further for that.
Commissioner Rady?
Yes. I've raised this before, and I remember when you presented to the Citizens Academy on this question, I raised this with you because it struck me both times. It sounds like an excellent program. What's missing seems to be the focus on critical incident stress and trauma coming from that is clear. But there's no mention at all of long-term stress, the daily tension of police work, the smaller incidents that don't add up to, you know, a dead kid or an officer-involved shooting or something that's severely traumatic right then, but the daily drip, drip, drip that adds up. And this is not something I'm inventing. From what I know of military psychology for soldiers, yes, a critical incident can cause a big, strong effect, but so can a long-term series over years of smaller incidents that don't quite meet that threshold. To what extent does the program address mental problems coming out of long-term stress?
So the traumatic leave policy in particular is dealing with critical incidents in the moment, that acute care, that acute Band-Aid. The long-term ongoing issues, which you're correct, are very real in law enforcement. We deal a lot with that. Those are issues that are being monitored and supported by our peer support team, that we see a lot of that wear and tear. And so those are when we're referring people to the clinical setting for ongoing counseling, maybe EMDR. Is everyone familiar with EMDR and things like that? So when we're seeing those in people, those are kind of the referrals. We also have the ability to file an 801 workers' comp claim on a psychological injury. A psychological injury can be something that is one event, this was it. It was like a clear delineation, or simply this job in general, the wear and tear of 20 years of doing this type of work has finally left me having some type of diagnosis.
How often do these two sorts of interventions take place? Is this a rare thing or a fairly regular thing? Could you give me any vague, spit in the wind statistics?
So the traumatic leave policy is used frequently.
Right.
I can't remember the numbers on exactly how many incidents we had that resulted in traumatic leave last year.
No, I'm just talking about the longer term, what you just talked about.
The longer term is, as far as filing an 801 for it, is less common. I think we've had a handful of those filed this year. And because there's particular, once you go into the workers' comp realm, there's particular things that have to happen, and we need a diagnosis from a medical doctor, not a mental health professional. So might not be the same, right? Not all mental health professionals are medical doctors. So they have a medical doctor involved, they have a mental health professional involved. And the good news about filing an 801 is that then the department will then pay for the care that they need, whether that's counseling, whether that's medical appointments, whether that's a retreat, some type of wellness retreat. But there's also documentation and requirements that are under that umbrella. So we try to do referral and support before that, if the 801.
And how often do you do the referral for support on those kind of?
We're doing that weekly. So that's where the work that is unreported by from our team. Like, we're referring people to counseling settings,
Yep.
we're referring people to rehab, we're referring people to their doctor for sleep meds, those types of things. So, and those are happening all of the time. That's like the bulk of the work that our team does.
That's very helpful because it gives us an idea of the size of the problem, which we're basically ignorant of.
Yeah.
Right.
Yeah. And so the other thing that we've started to do in the last couple years is there's a lot of funding that's becoming available from both the department, like the chief said, we're battling budget issues, but they try to find funding, but also from the police foundation around wellness and how important that is. So we're starting to try to identify what are some of the retreats and trainings that are really helpful for our people that are experiencing those long-term effects. And like the COPS conference, they have a national conference that's really, really good information, and you actually get to take your significant other with you, and they have classes for both of you. They have classes for the significant other, they have classes for the officer, and then we've got really good results from that. So if our team is having normal interactions with someone throughout the year where we're like, wow, this person has had a really hard year, they've been to all these incidents, they have a lot of cumulative stress, they have stress at home, those types of things, we're then saying, hey, would you benefit from going to this conference? Because we can get the department and the foundation to pay for you to go to a conference. We have someone going later this month with their spouse to that conference. So those types of things of what can we do for those long-term situations where we really need to be thinking outside the box and addressing them. And so that's some of what that work of what our department, our team doesn't have a huge budget. We only have a couple $1,000s that's actually identified for our team each year out of the budget. But there's other ways to find funding, and those CSI wellness funds. There's also, money through the foundation, grants. So we're really creative in trying to find money for employee wellness.
So we're actually coming up to 12:45, but I would like to ask if we can extend the meeting by, let's say, 10 minutes to start off with.
So moved.
Second.
All in favor?
Aye.
Commissioner,
The other thing that we're doing to support people post-incident is the critical incident stress debriefs. And that's that formal setting that's led by our department, that's led by our peer support members. But we also have a chaplain and a mental health professional present. And their role really is to provide support and education, and also to let us know if they see anything concerning, because they're trained in a clinical manner. Our people respond best to their peers. They want to hear from another officer or dispatcher that sat in a seat, that's done their job, that's been through a similar incident. That's who they want to communicate with them, and they generally will open up. Even with the clinical professional there, they will open up. And that's been really successful. But what that clinical mental health professional is doing is they're actually watching and assessing and listening for concerns about what those officers are saying. If an officer is saying, hey, I haven't slept, I had this fight with my spouse, or I am having reoccurring nightmares, or whatever it is, then they can kind of tell our team after, hey, I think you should circle back with that person, and they would benefit from EMDR, or you can refer them to counseling or things like that. They probably need some additional assistance, so you probably need to follow up with them. And so they're helping us to do those assessments as we're talking with them.
Commissioner Booker, did you have a?
Yes, I do appreciate what you're saying, but I do have to say that sometimes I understand your job is to protect the officers and be a source for them, but sometimes that can be a danger to the officers and to the public. And it seems like a lot of stuff when you're talking about long-term, you're talking about referrals and weekly counseling and rehab and sleeping pills and et cetera. Those seem like bandages on a bigger problem. Being a combat veteran and being deployed for 6 months to a year, every day wasn't something going on, but you still walk around with the stress of every day that something could happen, Then there were incidents where, I have to see people's bodies burned up or legs blown off or stomach blown up or head blown off. And when you are out of those situations and you go back to your home base, they will send you to a counselor, or they'll send you on something called R&R, and they expect you to basically release whatever it is that you saw that could have been traumatic. A lot of times lies are told, because again, there's the fear of losing your security clearance, not being able to return to duty, etc. Which, equating this to where our officers are going through on the long-term and short-term, I think as a commission, we really need to focus on there isn't a professional assessment going on. There isn't any professional help. This is still internal. And I know you're saying it's working, but of course, I think that's your job to say it's working. But on looking at what's not working. And if everybody's comfortable and nothing's changing, that's a problem. So I like to see what can change and what we can assess. And I feel like what this group could do, I would like to make a motion that we start to formally work on policy that ensures availability of a mental health professional well-versed in law enforcement culture and stress, that these officers can be made available to them. And some of those resources that are going to a weekly basis, and it's alarming that the traumatic leave is being used frequently, but the referral and rerouting these funds that you do have into assessing, researching, and getting a professional mental health professional that's versed in law enforcement culture. So I would like to make a motion that we start to immediately work on policy around ensuring the availability of a mental health professional well-versed in law enforcement culture and stress that can be made available to the officers. And then that health professional could offer suggestions to the officers and deem them necessary or fit for duty or not fit for duty. I think taking it out of an internal Boys and Girls Club and making it having that outside resources that could assess these officers in a professional way is helpful to the officers and to the public. But having these officers to continuously do this internal self-assessment, self-help, self-referral, self-leave is not beneficial to the officer long-term or short-term. Like I said, it's putting a band-aid on an open wound. Let me go back and say it again. I would like to make the motion that we start working on a policy that ensures availability of mental health professional well-versed in law enforcement culture and stress that can be made available to officers, and that person could offer suggestions of fit for duty or not fit for duty.
So why don't I review what we have done and what we're currently done in regards to that, and then you guys can talk about addressing the motions. So currently we have an extensive list of vetted mental health professionals, and when I say vetted, someone on our team has either received counseling from them in a clinical setting themselves, because many people on our team are combat vets or have been in an officer involved shooting, or have a variety of reasons why they themselves have attended counseling and kind of know what we're looking for, or I have met with them personally and vetted them through a process through Dr. Khan, who used to be an officer, went back to school to be a mental health professional, has written books, runs her own private practice out of Portland area that deals extensively with veterans and first responders. That's their only focus in their practice. She's kind of helped me kind of come through how are we going to vet some of these people. So we do that. We also talk to them about kind of what is their background and experience in dealing with first responders, talk to them of if they're taking new clients, and if some of them aren't taking new clients, but they're still willing to take Eugene Police officers if they call. They just have to identify that they're with Eugene Police. Do they accept our insurance? And if not, what are some other ways that that payment options that they have? We also do an internet search to make sure that there's no formal complaints that have been filed or investigations for that mental health professional, because those are all state documented. So it's all on the internet to check that. And that's usually a vetting process that gets updated on our resources yearly. We have someone on our team that does that. So we're doing that to identify those people. I have identified, there's not enough of them, but I have identified those people in our area that do deal with first responders, that are culturally competent, that do EMDR, things like that. And that's who we are referring people to. There are also out of area people that only do telehealth, or you have to commute an hour or two, but officers that are having a really hard time are often willing to drive an hour to get someone that they know is going to help them versus going to just whoever's in the yellow pages. As far as fitness for duty, that is a really hard topic. And the hard thing about it is these are union protected jobs. And fitness for duty brings up all kinds of things. Generally, there has to be some kind of reason, some kind of workers' comp claim, some kind of admin leave from an actual official misconduct or something like that that precipitates the need for that. Just saying that we're going to have a policy that says that everyone is going to be evaluated on fitness for duty, basically simply because you are a police officer and do police work. I can't imagine a world where the union's going to sign off on that. And we're going to get something like that passed through or be able to retain officers long term. But there certainly are times when that is valid, and there are times when the Human Resources Department and the city says we have to do this for this reason, and they are doing those fitness for duty evaluations.
Right. Well, my motion is basically for mandated, and I think that door needs to be kicked open, especially when you have traumatic leave, and I think that's well within reason to challenge the police union. If it's used frequently, this is traumatic leave that's being used. Those funds could be used for a mental health professional, not an in-house assessments. So my motion is for a mandated mental health professional, not a suggested.
Commissioner Hawkins.
Thanks, Chair Parham. So as a subcommittee, we can make a recommendation to Police Commission in general of a policy that we want to explore. And in no way are we trying to undermine the efforts that EPD is already putting in by providing the peer support and resiliency team. The services that Emily and her team provide are light years better than absolutely nothing at all. And so we have to be mindful about what we can accomplish as a subcommittee, and then what we can convince the rest of Police Commission to pursue as well. You may recall, Dr. Booker, I tried surfacing a motion to Police Commission very similarly along the lines, and there was a lot of discussion about it. So as a subcommittee, my recommendation would be that we use our next meeting, perhaps Chair Parham, to discuss the recommendation that we want to make to Police Commission.
Thank you, Commissioner Hawkins. I was actually going to ask if Dr. Booker, if you'd be comfortable tabling the vote today, so that we could possibly get some more written communication from the PRST team, so that we can kind of look over what they're currently doing, so that we can better form a better informed recommendation on that need for a actual outside person to review.
Yeah, I'll answer. I want to hear what Mr. Radley has to say first.
I had my hand up.
Sure. Commissioner Rady, and
yes.
Before I let you go, I just wanted to say, I wanted to ask if there was ability to get SOPs from the from the peer support team, or if there's like best practices or like anything that's written on your all's operations that would help us and to make this
So
work?
we have a department-wide policy that dictates the operations of our team, and then we have the post-traumatic incident policy, which it has that traumatic leave policy embedded in it. Those are the two main frameworks that we're working under right now. We do have our peer support lead team members working on a kind of an internal SOP policy, and that's really just has to do with like emergency notifications and some of those selection of team members and some of those other things that we do. That is a project that actually just started last month, so none of those have been created yet. But I can provide those other two policies to
Would
you.
it be helpful for this committee to work with y'all on that at all, or to possibly like be involved in the SOP creation? Because I think that's hitting to a lot of what Dr. Booker is commenting on right now, is that there's no SOP. And this also goes back into what the chief was saying about seeing areas of policy that can be formalized.
I certainly think that it wouldn't be a bad idea for this committee to review that after we've created it. Like, hey, this is what we're doing now, and because that's what we're trying to do, capture what our team currently is doing, because so much of what we're doing is kind of unwritten, and we're creating it as the incidents come up. And so reviewing that once it's created, and then say, hey, I see some gaps here, or I think that that's where those recommendations would be helpful after it's been created.
Thank you. Commissioner Rady?
Yes. First, Commissioner Booker made a motion. It has not yet been seconded. Normal procedure is someone makes a motion, chair asks for a second. I'm not trying to be a wise ass, but it would really keep things clearer what we're doing. If there is a second, then we discuss it. If there is no second, then there is no motion on the floor and we move on. As yet, we have no second, and a second point in terms of parliamentary work with a motion, it's usually best if a motion addresses one issue rather than two or three, because there were several items that came up in Commissioner Booker's motion, and they are not all the same thing, and it might be more useful to separate the questions if we have a motion on the floor. That's all.
So I'm going to motion to table this discussion until next week.
There's no motion on the floor, so we cannot table it.
Oh, I see what you're saying. Okay, heard. Okay, then yeah, we're coming up against 1 p.m. and it looks like we have no motion, so we don't need to table anything. But it does look like we have something on the agenda for next week that bears more discussion.
But just for correction, Chair, there was a motion, but I will rescind my motion until we can further discuss this. But my motion, I think, is pretty clear on making mandated availability for a mental health professional.
I think the thing was that no one seconded it, so that was why that's why they're saying there's no motion.
Gotcha.
So real quick, because I think I'm wrapping up the piece that you need me to address. One more piece that we are doing that has been mandated is the training associated and available to officers. So rather than making our wellness training optional for training they can put into and attend, we started to embed that into our patrol in services, where it's like you're required to go to patrol in service, and this is part of your annual training. And so some things we've done in the last couple of years in regards to that is resiliency training, which was an outside speaker and a nationwide speaker that's well known, police ethics, and then what we're doing in November is suicide awareness, and that's being done by Dr. Khan out of Portland. And earlier this year, our peer support team had a suicide intervention training that was mandatory as well. So some of those topics where we're like, hey, we all need this, you all need to hear this. It's not just doing firearms and EVOC and defensive tactics. Like, we need wellness as part of that normal ongoing annual training. So that is being put into place in our department.
Thank you. And then Dr. Booker, would you be able to possibly write out the motion that you had so that it could be included in the agenda for next week?
Yes.
Cool.
Yes.
Perfect.
Oh, yeah.
Thank you, Dr. Booker.
Oh, thank you.
All right. So we're at time. We're a little bit over time. Does anyone have any closing comments or any final words or thoughts?
Just like to thank Miss Emily and Miss Holly and Chief for being here and helping us to push this along and make sure that we are an effective subcommittee.
Agreed. Thank y'all very much. I hope y'all have a great Thursday and a good weekend.
Thank you. I appreciate you guys.
Take care.